Hello, this is Dr. Matt Martin, and in 12 minutes or less, I'm going to be talking about complicated diverticulitis. I have no disclosures or conflicts other than I think complicated is not a meaningful categorization. And that's partially due to the wide range of pathologies that fall under the category of complicated in the literature. And the classic teaching was that all of these would require an operation, either urgently or electively after resolution. And I think we're learning that there's a wide disparity in the rates of these complications needing further interventions. I prefer to categorize complicated disease by primary or intrinsic processes like stricture mass, obstruction, or fistula. And these almost always require an immediate surgery or a surgery after temporization. And I would even add to this refractory to medical management or chronic relapsing diverticulitis. I compare that to secondary or extrinsic complicated disease, things like phlegmon, any abscess, free air on CT, or even localized air on CT. And as I think we're learning, many of these may not require an operation. Bleeding would also fall under this category, although it's extremely rare to have bleeding with acute diverticulitis. And I'm primarily going to be focusing on issues with things in this category. This is just an example case. This is an elderly female with multiple medical problems, including a recent CHF exacerbation. She's anticoagulated. She's had 24 hours of abdominal pain and fevers consistent with diverticulitis, and she has a CAT scan that's pretty characteristic of classic significant sigmoid diverticulitis, but no abscess, no large free air. So this patient was admitted with medical management. However, 1 week later, she's in the hospital. She's still having pain. In fact, it's increased now. She's febrile. Her white count is only 9. Her chemistry is normal, but her exam is significant for diffuse tenderness, but no peritonitis yet. And a repeat imaging is obtained. And she now has obvious progression of her disease, some more diffuse free fluid, and what looks like a focal fluid collection or abscess in the pelvis. And then the question becomes what to do with this in this elderly female with multiple medical problems. Should this patient have perc drainage? Should she have an operation? Should we continue medical management? And these are some of the common conundrums we face. Somebody with Hinchey 3 diverticulitis, now what? As in this patient, what's the best option? I think we know Hinchey 1 and 2 and 4, what to do, and Hinchey 3 is the one where there are more options and divergent pathways. What about elderly patients, multiple medical problems? How does that impact not only the type and timing of intervention, but whether they would need an intervention at all and the expected outcomes? What about patients with an abscess? Are there ones that we can observe only with antibiotics? Do we have to drain them all? And if they had one, does that relegate them to needing surgery electively? And if they succeed in non-operative management, again, do all these patients need to go on to elective resection? What about patients who need urgent surgery? And I think this is a big issue. Should we do a Hartmann's procedure? Are they better off with a primary anastomosis? Should we do this laparoscopically, even for urgent surgeries? And then finally, if you want to get a crowd really arguing, what about the role of laparoscopic lavage for acute diverticulitis? I'll start with the ideal operation or approach. And again, I'm not going to debate the merits of MIS. I think this is the most evidence-based intervention in all of surgery. If you can do something MIS, then it has a clear benefit in terms of patient outcomes. So I think we should be doing as many of these as possible using MIS techniques. So that leaves us with the choice of Hartmann's versus anastomosis. And I think, again, here, the literature is pretty clear. This is a meta-analysis. This is just the randomized trial data. And this shows no difference in overall complication rates or postoperative mortality for patients with acute diverticulitis requiring surgery undergoing Hartmann's or an anastomosis. And as a Hartmann's carries a colostomy with it, I think this really should lead us to question when we should be doing and why we should be doing Hartmann's procedures. This is additional data analysis, and what is really striking is the freedom from stoma is significantly higher in patients with a primary anastomosis, and those stoma-related complications are significantly lower in those patients. And this has been pretty consistent throughout the literature with Hartmann's versus primary anastomosis. In fact, I've yet to find a decent study that shows a benefit of Hartmann's in any defined patient population. It is a morbid procedure. You have to include the take-back risks if you're analyzing or comparing this to any other intervention. 30 to 50% of patients who have this never end up getting their colostomy reversed. And most patients can have a primary anastomosis with or without a protective diverting loop ileostomy. So I think, in my opinion, Hartmann should be our least commonly used option. Unfortunately, as some additional recent studies have shown, it is still our most commonly used option for emergent surgery for acute diverticulitis, and I think that's something we need to work on. The other thing is the sigmoid appearance isn't a critical factor. I don't care much what the sigmoid that I'm taking out looks like. I care what the remaining bowel looks like. And if after the resection you have healthy bowel that you can hook up to healthy bowel, then we should be hooking them up. It doesn't matter how bad the piece of colon that we took out looked. We have additional adjuncts that can further minimize complications with doing anastomoses. This is fluorescence angioimaging. And you can see here, that's a piece of bowel that externally looks like it's relatively well perfused, but using the SPY, you can see there's a large portion of it that has no perfusion. And thus, this can help guide resection and making sure we're hooking up healthy bowel to healthy rectum. So that leads us to abscess management, and we know 20 to 25% of patients with diverticulitis will have an abscess. Does everybody need to be percutaneously drained? This is one study, and it showed abscesses less than 3 centimeters actually had 100% resolution with IV antibiotics alone. 1/3 of those patients did go on to require surgery, but 2/3 of patients then who had an abscess, which traditionally is complicated disease, did not require subsequent surgery. However, larger abscesses still had a 50% resolution, so lower resolution with IV antibiotics. Half of them needed intervention. And then over half of the patients did go on to need surgery even after resolution of symptoms in the abscess with percutaneous drainage. So I think size is one criteria that can help guide our abscess management. The other is location. There are worse outcomes in terms of a higher recurrence rate and more need for surgery in patients with pelvic abscess versus mesocolic. We know that small can be managed with IV antibiotics alone. The recurrence rates are anywhere from 20 to 40%. And thus, in low-risk cases or high-risk patients, it may be reasonable to observe them after an episode of complicated diverticulitis with an abscess rather than pursue elective resection. Laparoscopic lavage is one of the very hot topics. There was a lot of excitement and hype with this as an intervention for Hinchey 3 and 4 diverticulitis, where traditionally we would be doing a Hartmann's procedure. And this just involves a washout and large volume lavage with minimal dissection and then placement of the surgical drain as shown here. We now have a reasonable body of good evidence on this. This is 3 of the main randomized trials on laparoscopic lavage: the Lola trial, Ladies trial, and Dalala trial. Unfortunately, these had conflicting results, with 2 of them arguing against laparoscopic lavage and 1 of them arguing for laparoscopic lavage with a lower reintervention rate. These studies are plagued by major classification issues of how they classified the need for reoperations or reinterventions. But all 3 of them are pretty consistent in showing equivalent morbidity and mortality other than the reintervention rate. It also appears that there's differential benefits, and a Hinchey grade 3 is more amenable to a laparoscopic lavage and has better outcomes, and Hinchey grade 4 seem to be the ones that fail and have worse outcomes. One other thing, though, that is pretty consistent is the decreased stoma rates associated with laparoscopic lavage compared to resectional therapy. And I think that has to be factored into any discussion about the ultimate benefit of this intervention. And these are 2 meta-analyses published at nearly the same time, analyzing essentially the same data, and they highlight this problem. These two studies analyzing the same data came to exactly opposite results, one saying lavage is supported, the other saying lavage should not be performed. So this just further sows the seeds of confusion on this topic. We do now have some long-term follow-up from 2 of those randomized studies. These are the 2-year results from the Dalala trial. 7% stoma rate with lavage versus 23% for resectional therapy. And similarly, in the 1-year SCANDIV results, 14% ostomy versus 32% with resectional therapy. So again, I factor this into my decision when I'm thinking about should a patient have a laparoscopic lavage. And I would personally trade a decent amount of morbidity for avoiding an unnecessary stoma. So what is the role of laparoscopic lavage in my mind? The literature and the results are all over the map. The techniques and patient selection are also highly variable. And I think that's where the key principles lie. I think it clearly can be effective in highly selected Hinchey grade 3 patients. I think it can also be misused in Hinchey 1 or 2, where they probably would have done fine with nothing, and Hinchey grade 4, where they probably should have a resectional procedure. So I do use it, but it's a very uncommonly. It's a highly select patient population with a risk-benefit ratio that favors avoiding an emergent resection. And I also think it does help avoid stoma versus other complications. And this brings us back to the case that started off the talk, our elderly female who's now been in the hospital for a week and with persistent diverticulitis and worse pain and progression on CT. So to make a long story short, what we did is we took this patient, we did a laparoscopic lavage. This is one of the very few that I do. We washed her out. She had Hinchey 3. We left a drain. She actually did well, was discharged home 2 days later, and she's now been seen in follow-up and is symptom-free. I'm going to close with 2 current hot topics I just want to mention before I end this talk. One is there's a lot of talk now about not needing antibiotics for diverticulitis. This is the most recent randomized trial. There are now multiple of them that have shown antibiotics versus no antibiotics have equivalent outcomes. I now see this creeping into a lot of discussions on the topic, but being applied inappropriately. This is for mild outpatient management of diverticulitis. So I just want to highlight that there is no good data yet for more severe diverticulitis in inpatient management, that not giving antibiotics is a safe approach. The other interesting study that also recently came out was the laser trial. And this was 90 patients who had recurrent, complicated, or persistent pain after diverticulitis. And they randomized them to an elective resection versus medical management. And interestingly, this found a significantly improved quality of life and lower pain scores with the patients that were randomized to elective resection versus those that were just managed medically. So I think the pendulum may be swinging again. I think we were very liberal with doing surgery for this. It then swung to where we were avoiding surgery in most patients, even with recurrence, even with very young patients. I do think now, especially with this laser trial data and some other trial data, we may now be swinging back towards more frequent use of elective surgical resection in some of these patients who do have persistent symptoms. I want to thank the moderators for inviting me and the American College of Surgeons for the honor of the podium. And I look forward to the discussion in the panel session. Thank you very much.